So thank you so much for joining me. It's been a couple of months. I got kicked down by the lurgy, the dreaded COVID lurgy last month. So this one's a bit of a delayed topic, but coming to you, as I said, from Longreach. My name's Suean Pascoe. I will be hosting the coaching corner tonight. I'm going to just remind you that this session is being recorded. So feel free to ask questions, or whether if you'd rather ask questions offline, let me know and we can come back to you at the end of the session. I'm going to just let you all know that the previous episodes of the coaching quarter are recorded and available on our website for free. And the other thing, if I could ask you all now to mute yourselves, and it'd be really good for the time being, just for a bandwidth thing, given we're going off the phone and technology, I hope is going to work. But if we can just mute yourself and turn off your camera for the time being, please. Now, the other thing I wanted to just take a little moment to mention is and I was just talking about this with Chris, I wanted to let you know we've just held our first Train the Ultrasound Trainer course in Australia last weekend, and it was fantastic. Everyone had a great time. We're all motivated, got new teaching tips. We're hosting this again in Melbourne in October. This course has been internationally recognised. I've delivered it in Denmark and in the States, and it's highly recommended for anyone who's passionate about becoming the best ultrasound instructor you can be. So there's no ultrasound machines in this one. This is teaching you the tips and tricks of how to teach better. So if you like, you can join us. You can go to the website and see the details of that course. And the other thing that I wanted to mention too is that we've just started a new Facebook group called POCUS Educators and Sonographer Educators in the ED. We're building up resources and stuff, and we want that to be a nice place that everyone can come, get tips and tricks, bounce ideas off other people, and get some ideas for their teaching. So if you haven't already joined us there, feel free to do so. Now, tonight's topic for the coaching corner is on request. We're looking at breast ultrasound. Now, I'm not doing the high-end fancy stuff that they do in breast screening. This is the basic how-to with some of the key points for scanning technique. And at this stage, I do want to acknowledge Jacqui Terry, one of our educators at Zedu. She has done an amazing job at helping me put together these slides for the coaching corner tonight. So the way we're going to run, we're going to start and have a look at a little bit of anatomy. I'm going to take you through the sonographic technique, look at some sonographic appearances and some common pathologies, and then go through some tips and tricks. So there are a lot of indications for having a breast ultrasound. Ultrasound is often performed in conjunction with other tests, and it's based on the patient's presentation, the indication of the scan, their age, etc. A lot of people have routine screening examinations, and certainly in Australia, that routine screening happens after 50. So they'll go for a mammogram and then maybe get an ultrasound, and then the studies are often reported or will be reported together. Younger, dense breasts are better assessed with ultrasound because they have a lot more glandular tissue. And as the breast ages, it becomes more fatty, and so it's easier to kind of do the mammogram. The appearance of the ultrasound depends on the degree of dense breast tissue versus fatty replacement. And you'll find at different places there are different protocols for how to do it. I'm going to share with you the way I tackle the breast. It's not the only way, but certainly I find it interesting when I'm talking to other sonographers. It's amazing, we all do what we do and go to work and think we're doing a good job, but we never talk to each other and share notes. So feel free if you've got something you'd strongly disagree with, or if this just helps confirm, hey, I'm going about it and someone else does it the same way as me, that's all great. So we're going to start with the anatomy. There are a wide range of sizes and composition of the breast, and that composition, as I've already mentioned, changes with the patient's age. So both male and female breasts are underdeveloped until the age of approximately 10 to 12 years. And thalarc is the start of breast maturity in the female, and the male breast remains immature. The breast tissue sits anterior to the pectoralis major muscle, to the serratus and external oblique muscles. It's bordered by the sternum medially and laterally it's bordered by the margin of the axilla. Now the superior portion sits at about the second or third rib. It consists of two different types of tissue, the breast parenchyma and the breast stroma. The breast parenchyma includes the lobes, lobules and ducts, and the breast stroma contains the fat and the connective tissue. So the Cooper's ligaments then provide suspension and support for the breast tissue. The skin of the breast is thin, contains hair follicles, sebaceous glands and sweat glands. So in each breast, we have approximately 15 to 20 lobes, and these lobes are then further divided into lobules. And the space between the lobes is filled with the connective tissue, including fat. The lobules are made up of branched alveolar glands, and each lobe drains into a major lactiferous duct. The lactiferous ducts dilate into a lactiferous sinus beneath the areola and then open through that constricted orifice onto the nipple. So just to recap here, each lobe has its own pathway to the nipple via the ductal system. Now, the scan technique is important, and in breast ultrasound, we often use different terms compared to when we do other parts of the body. So in other parts of the body, we look at long and short axis of things. In breast, we use different terminology. So to begin with, we're going to make sure we are across the 4 Ps. And the first step is choose the right probe for the job. Second is choosing the right preset. Third is putting your patient data in. And lastly, we look at the positioning of the patient. Now, with your probe choice, you want a high frequency probe, and dedicated breast probes or probes that are more suitable for breast tissue usually have a little bit of a wider footprint. So instead of your regular sort of, I think 38 millimeters, 40 millimeters, you can get probes that are wider in their footprint, so about 50 millimeters wide, and they're a higher frequency probe as well, because we're now trying to pick up tiny little changes and small changes or cancers in ductal tissue, which might only be, a couple of millimeters or so. When we're positioning the breast, or positioning the patient so that we have the breast in the right position, it's important to get our patient comfortable and to protect their privacy. So I typically will cover the breast that I'm not scanning with a sheet so that they just feel a little more comfortable. I have the patient supine on the bed or just rolled up slightly onto the contralateral side with either a small wedge or a towel placed under their back for support. I want their arm up above their head so that they're in a comfortable position that they can maintain for the duration of the scan. Now, what I'm trying to achieve is an even distribution of the breast tissue on the chest wall. And I kind of think of this as like a jelly bowl on a plate. You want it positioned squarely. You don't want it falling off to one side or another. So for some patients, it depends on the size of their breast, how much you may need to roll them up, but you don't want the breast flopping medially or hanging out under their arm, because then you haven't got access to it. We're trying to position that breast tissue right on the chest wall and to flatten out the breast tissue so that it's even thickness for us to scan. And then whatever makes them comfortable. If you've got wedges, put it under their shoulder to help support the position. It's really important in breast ultrasound to scan the breast entirely in at least 2 planes and correlate the pathology with any other imaging. So often we'll go into a breast exam, we have the mammogram, we know that there's a lesion in XYZ spot, and you are looking very closely in that spot as well to correlate, well, what do we find at that spot? Now, we've got the lion with its cub in its mouth because, as everyone doing ultrasound knows, you can take a series of images that don't tell the picture of the story that you saw on the day. You can get artifacts, and often it's very easy to just freeze the picture and not realize you have an artifact. So be very careful when you're taking your pictures that the pictures that you take are representative of what was going on for the patient that day. And just like these lions, if we only had the right-hand picture here, we think this lion's eaten its baby. But when you look at that same lion from a different view, it actually looks different. If it's true pathology, it's going to be there in 2 planes, whereas an artifact will typically disappear in one of those planes. So really important to scan in 2 planes. Now, when we label our images here, we imagine the breast and the breast tissue as a clock face with the nipple at the center. Each number of the clock corresponds to a section of the breast, and we'll document it that if we find a lesion, for example, that it's at 1 o'clock and however many centimeters away from the nipple. So for example, right breast, 11 o'clock, 4 centimeters from the nipple. And again, we need to have a look at that, measure in 2 planes to confirm that it's real and not an artifact. The other language that we use in breast ultrasound, instead of the long and the trans, we're using radial and anti-radial. And these refer to the position of the probe relative to the breast. These terms are unique to breast ultrasound. So the radial scan is the way that the clock hands would tick around the clock. In this case, the purple line, and the blue line represents the anti-radial position, which is the orthogonal view of that same spot in a different scanning plane. Different people will scan in different patterns. There are many different ways to survey the breast. You can use a cross-grid approach, or you can use this radial circular approach. I tend to do both. I spend a lot more time survey scanning the breast, and then taking the images afterwards is much more quicker once we've discovered and figured out, well, what's actually going on. So I tend to scan radially first, and then I also do a cross hatch. I'm super paranoid about missing things. So it's really important that you do try and scan the breast tissue in a couple of different planes, or maybe use a couple of different approaches so that you be sure you've got all the parts that we need. I start in that 12 o'clock position, and what I want to do is start at the edge of the breast tissue and then move my probe towards the nipple. And what I'm trying to do here is pick up the breast tissue as we go, so I see all the breast tissue. And then we don't want to be sort of going from the nipple and moving out, because you can sort of, at the edge of the breast tissue, you kind of create a fold in the tissue and you can miss lesions here. So we start from the outside of the breast and work our way towards the nipple. Then we move to the 1 o'clock position and pull it towards the nipple. Move to the 2 o'clock position and pull it towards the nipple. And we carry on that the whole way around the breast. Again, we want to collect the breast tissue at the lateral margins, because we don't want to miss a lesion here, and we want to pull that towards the nipple. And once we've gone the whole way around the clock, then we're going to position sort of superiorly, inferiorly, and fan our probe so that we're looking behind the nipple to get a good view of the retroareolar area. And I do this in transverse orientation, a typical transverse here and a typical longitudinal, so on each side of the nipple, to make sure that I've seen behind the nipple as well as I can. Then we come up and I scan the tail of the breast, and I do kind of a grid pattern up in the tail of the breast, looking for any lymph nodes and making sure that I have seen all the breast tissue that kind of extends up into the breast. My thing then is to go through and repeat and go in a like a mow the lawn kind of technique, where I do this crosshatch grid, scanning it in a traditionally long and transverse orientation, to make sure that I've covered that breast tissue. Like I said, I think breast ultrasound can be a little bit mesmerizing. It's kind of, you know, you're watching the waves, and you have to have your eyes peeled at all times so you don't miss those small changes. And often it's just the small change that alerts you to something is there. And so I'm super paranoid. I do scan the breast in that radial pattern from the outside in, as I just said, and I cross-hatch grid it then, and then I go back and take my images. I'm sure there are many different ways that different sonographers use. So what are the sonographic signatures of normal breast tissue? The sonographic appearances can be very variable depending on factors like age, the functional state of the breast, and whether they've had any previous breast surgeries. The 3 layers of the breast can be distinguished on ultrasound, and you need to be careful to set your depth so that you can see all the breast tissue to the chest wall. The premammary layer is the skin and the underlying breast fat. The mammary layer is the fibroglandular tissue, the fat lobules will be seen interspersed between the glandular tissue, and the amount of fat tissue depends on age and the functional state of the breast. And then we see the retromammary layer containing mainly fat, lymphatics, and fibrous tissue, which sits just anterior to the pectoralis major muscle. This is a radial image of the breast, with fat within the breast appearing hypoechoic compared to the surrounding breast parenchyma. The glandular tissue appears hypoechoic compared to the fat, hyperechoic, so brighter, compared to the fat. The Cooper's ligaments are quite echogenic, little white lines, and they can be seen within the glandular tissue. And in this case, the chest wall, the rib with posterior shadowing, can also be seen here deep to the breast. The breast ducts, sometimes you can see these. Just making a little adjustment here. So the breast ducts are sometimes quite visible. You have to get quite perpendicular to them to see them nice and clearly so that you get reflection from the walls of the ducts. And it's important to have a look, if you see these, have a look at them. They often look anechoic with echogenic walls. And what you're looking for are any signs of echoes or solid content within the duct. If so, you need to have a look and put the colour on to just check and see whether there's any flow. Now, the most common type of disease that we see that's benign is cystic breast disease. And it's quite common to see cystic breasts. I think the hardest thing to do is when you have a lady with large breasts and she's got multiple cysts everywhere, and it's hard to keep on top and know which ones to measure. And I tend to try to go, okay, well, where are the biggest ones that might be symptomatic, or which one corresponds to the lump? But often there are very many number of cysts and you can't measure all of them. We do our best to try, but that's when going around and going 1 o'clock, 2 o'clock, 3 o'clock, so that exam can be repeatable. We can follow up on that cyst, so the next person scanning you knows what you've done and can repeat a similar exam. Now, breast cysts come and go. Sometimes they can be associated with fibrocystic disease. Often the patient might have irregular, dense, lumpy breasts and have fibrous and cystic components. The patient may have tender and swollen, lumpy breasts, and the appearances might fluctuate with hormonal factors. Breast cysts are a benign process as long as they are simple cysts, and a simple cyst is a well-defined anechoic area with posterior acoustic shadowing with smooth, regular walls. If it doesn't look like that, then it's not a simple cyst, and particularly if it has stuff in it. Here is an example of a simple cyst. Smooth, well-defined walls. It's anechoic with posterior acoustic enhancement. Cysts can be quite variable in size, number, and location, and we use the same criteria as other areas to call something a cyst. The smooth-walled, round, anechoic, good posterior enhancement. There shouldn't be any flow within them either. So if you pop the colour on, there shouldn't be any flow within a simple cyst. Sometimes if those cysts are quite large, an ultrasound-guided aspiration is performed so that the patient can get some symptomatic relief. Now, complex cysts, sometimes the cyst doesn't meet that simple cyst criteria, and that's okay. You just need to look at these features very carefully. Now, this is an image not of a simple cyst, but of a complex cyst. And so you can see the complex area to the right of the screen here. We have a good simple bit over here, but the edge of this is looking a little bit irregular and it looks like some solid component here. So within a portion of that cyst. These are radial and anti-radial images of what looks like to be a cluster of 6 cysts. It was actually fibrocystic change, and fibrocystic breast change is common and a benign change within the breast that's characterised by dense and irregular and bumpy consistency in the breast tissue. But all of this little cluster, they all look like they're simple cysts. So what happens when the mass isn't cystic? And what if it does look solid? Many solid areas can be seen within the breast. Not all of them will be malignant. So it's really important to look carefully at the features. Fibroadenomas are quite common. They're a benign solid mass of the breast. They're often seen in younger women and can be confirmed with a core biopsy or with follow-up ultrasound. So these benign lesions are composed of fibrous and glandular tissue. They have very well-defined margins. They're usually wider than they are tall, and they can have a bit of variability about their shape, but they usually have that thin echogenic capsule. This was a patient, so some patients might just choose to go through and have a breast biopsy to make sure that it is a fibroadenoma rather than a malignant mass, rather than go, there's serial scans as well. So they just want to get an answer. I think I would, but anyway, this mass here starts to look a bit suspicious because it's starting to look a bit deeper than it is wide, but it was proved as a fibroadenoma on a breast biopsy. Breast cancer is obviously the whole reason why we're doing these and why there's so much screening work done and why people come to you very anxious for their breast ultrasound. It's a common cancer in Australian women, and there are many different types of breast malignancies, like ductal carcinoma in situ, which is the most common, but you could also have lobular carcinoma in situ. The risk factors for breast cancer include being female, a family history of breast cancer, if they've got the BRCA gene, female hormone exposure, if they have themselves a past history of breast cancer. And then there are other lifestyle factors such as being overweight, limited physical activity, and increased alcohol intake. The survival rates here depend on how early we find it and how far it's spread. So malignant masses, they kind of have particular features that indicate that this is suspicious for malignancy. They often have spiculated borders or thick and echogenic halos. They have angular margins, sometimes microlobulations. Typically, they are taller rather than wide and show, sometimes they can show acoustic shadowing. If we can see the duct, sometimes you can see ductal extension in it, or calcifications, and they're typically markedly hypoechoic. There's no single appearance or one thing that, hey, that looks like breast carcinoma. We're looking for those features. Now, all of these images here are biopsy-proven carcinomas, and they all look very different. So sometimes it's the presence of a group of features that look okay, so no posterior shadowing, and sometimes they don't. They're slightly irregular shaped. The area commonly needs to go undergo further workup to figure out, what's going on. Now, the reporting system that they use is called the BI-RADS reporting system, and that's used by the radiologist to classify these studies. And we'll come to that a little bit later as well. Now, this is an image of an intracystic papillary carcinoma proven on biopsy, quite smooth-walled, predominantly cystic mass, and it's a clinically palpable mass here. It was not a simple cyst though, and it contained an irregular lobulated solid mass on one wall. And this mass didn't change with patient movement, as you would expect internal mobile debris to do. So if you're thinking this might be like an abscess or something like that, and it was debris within the cystic area, then you can reposition your patient and see if that stuff moves. And if it stays fixed, well, and doesn't move its position, well, then it's obviously increasing your suspicion for something nasty. Now, as I mentioned, the BI-RADS, or the Breast Imaging Reporter and Data System, is a risk assessment and quality assurance tool that was developed by the American College of Radiology that provides a widely accepted lexicon and reporting schema for imaging the breast. And it applies to both mammography, ultrasound, and MRI. So it separates the findings into defined categories and also helps to standardize reports. If you look at how much the lesion is taller than wide in comparison to the chest wall, it's a really useful detail. And so use the calipers here. If you're not quite sure, use the calipers to confirm your thoughts. Malignant masses are commonly taller than wide because they invade the different layers of the breast. So, sonographic features, one of the things that we look for and in staging breast cancer is to see if there's any lymph node involvement. So we do need to make sure we go up into the axilla and carefully examine the axilla. We're looking at the extension of the breast tissue in the axilla, but we're also looking for any lymph nodes, because if there is cancer, the first place that it's going to go to is the axilla. And the lymph nodes, of course, are part of the immune system that filter the substances traveling through lymphatic fluid, helping to fight infection and disease. So if there's disease in the breast, the lymph nodes in the axilla are the ones that drain the breast tissue. That's the first place that the breast cancer will metastasize to. The lymph nodes are normally small bean-shaped structures that are enclosed in a capsule, divided into different regions with the capsule and the cortex and the hilum. The hilum is the portion where the vessels exit the lymph node. And so we can see lymph nodes quite easily on ultrasound, and they have very classical appearance when they have this sort of little mini kidney bean shape when they're normal. And when they're abnormal, they start to get irregular shaped and things start to change. And so they can be abnormal because of inflammatory processes. So let's say your patient's had a big cut that got infected on their hand. They can have inflammatory processes going on and lymphatic drainage and inflammation of the lymph nodes, or we can have the cancer cells draining to the lymph nodes, causing local infiltration of the lymph nodes. So it's important to understand the differences of an inflammatory lymph node versus a nasty looking lymph node that represents carcinoma spread. Here is a normal lymph node, and they're commonly seen when scanning, even if they haven't got a lump. And that's because it is the drainage area for the arm. And so if you've had a cut on your finger or, you know, anything, you can get lymph glands in your axilla. The normal lymph node is ovoid in shape, hypoechoic in the cortex, and an echogenic central hilum. This lymph node has, the image here has calipers measuring the short axis of the lymph node. So usually they're oval shaped, well defined. The short axis of a normal lymph node should be less than about 1 centimetre. Sometimes they're quite long and thin, and there's quite a bit of variability in how long and thin they can be. So we use the short axis as a guide for whether this is inflamed or looking abnormal. The normal lymph node has a cortical thickness that's less than 3 millimetres. And sometimes it's not even the biggest portion of it, but you can measure the cortical thickness and the short axis. Now we're looking for the internal architecture. We want a hypoechoic cortex and a more echogenic central hilum portion of the lymph node. So be careful with your gain settings here. You just need to make sure that it's not too bright. And if you are suspicious of inflammatory change, put the colour on, and then you'll see hypervascularity in a tree-like pattern. Whereas when there is carcinoma involvement and cancer spread, there's distortion of that tree-like pattern of the lymph node. So here's an example. This is a normal lymph node where the cortical thickness is measuring less than 3 millimetres. Sometimes they can look like little clouds. Here's an abnormal lymph node. And you can look at this and immediately see something's not quite right. We have calcification. It's bigger than 1 centimetre in its short axis. It's grossly abnormal here. And there's none of that normal architecture, the central echogenic hilum, hypoechoic edges, and any tree-like sort of pattern of vascularity here. Not that we're looking at vascularity, but you can see that this is quite different to our previous picture. This lymph node is also grossly abnormal with the loss of normal features and edema of the surrounding areas. And here is another lymph node too that is also abnormal. And again, we've lost that echogenic central hilum here. It's diffusely diffusely hypoechoic, no hilum is seen, and at the left-hand side of this, there's some irregular margins. It's important to look as closely as you can because sometimes it can be really subtle. And the more lymph nodes you look at, the easier this gets to appreciate. This lymph node is also quite abnormal with a loss of those normal features. The cortical thickness is quite irregular and thickened. Now here's a couple of case studies of some other pathology that you might see. So that's covered off on nasties or carcinomas. We've got fibroadenomas, cystic disease, and normal and abnormal lymph nodes. But every now and then you may have a patient who has a breast implant, either because of it's a cosmetic or because of post-surgical procedure. So these images are of a lady who had implants done following her breast reconstruction after a mastectomy. It's important to have a look at the remaining, she didn't have a mastectomy, she only had partial sort of lumpectomy, but it's important to look at this, the remaining breast tissue, and then look at the implant to make sure that it's intact and the walls are nice and smooth. It's a bit tricky though, because the fluid, if these are saline implants, so they transmit the sound really, really easily, and you're going to need to make adjustments to your gain settings to make sure you get rid of any near field reverberation. So looking for any signs of leaking and things like that. Here is a 50-year-old lady. She presented with a hard palpable mass that was imaged on mammography as a dense rounded lesion in the right upper breast, adjacent to a silicone-filled implant. So the implants had been in place for about 18 years and there'd been no injury or anything, but the patient was concerned about this palpable lump. And here you can see the surface was quite irregular and there's dirty shadowing seen posteriorly. And this is typical of extracapsular spread of silicone causing a local reaction with the tissues and a granuloma formation. So this is just through here is a silicone granuloma with extracapsular spread. Now this is an image of a galactocele patient who is breastfeeding. It's the most common kind of benign breast lesion in young lactating women. They mostly happen once they stop breastfeeding. So clinical presentation, the patients usually present with a painless breast lump occurring over weeks to months. And the lesion can present as a single or multiple nodules that can either be unilateral or bilateral. Sometimes you can get secondary infection and development of breast abscesses. This is a phyllodes, and I hope I'm saying that right, a phyllodes tumour, which is also known as a cystosarcoma phyllodes. It's a rare fibroepithelial tumour of the breast and has some resemblance to a fibroadenoma, but is typically a large, fast-growing mass that forms from the periductal stroma of the breast. You may need to put a curved probe on here to see if you can get visualize the whole of the breast lump. So you can see on the right-hand side here, we've used the curved probe to show the extent of how big this is. Linear is good for the detail, but the curve gives you a better appreciation of the true size. MRI can also be used for breast imaging, and so you can see an enhanced focal area within the right breast here. And this is and on the right-hand side here, we have a mammogram image of a specimen. The hook wire was inserted under ultrasound guidance and the patient taken to theatre so that they could make sure they had the lump. And then they bring the tissue down and you do a mammogram to make sure you've got the same area that was seen on the mammography. Now, some other things that can happen often enough are breast abscesses. They're relatively rare, but they're a significant complication of mastitis, and they can occur, of course, during breastfeeding, particularly in primiparous women. The clinical context is a key to diagnosis, and because the appearances here can mimic many other things, including a breast carcinoma. So it's really good to get a history here. Have they had a fever? You know, is there red swollen tissue around it? Are they breastfeeding? The most common, here's another breast abscess, so they can look like anything, and you can potentially, if you know that this is a breast abscess, they shouldn't have any colour flow within it. If it's pus and stuff, there shouldn't be colour flow within it. So it's a good idea to pop the colour on here to make sure there's no flow. Here's an abscess in a non-lactating breast. They're less commonly seen, and they're typically in older women with chronic underlying medical conditions such as diabetes or rheumatoid arthritis, ladies who are taking steroids, or even potentially after they've had a recent breast intervention such as a biopsy or something like that. So you can see here, the middle picture is labelled as compression. And so what we're doing is just trying to push on the breast tissue to see if it squishes a little bit, because if it squishes, it's more fluid-like. And we're looking for pustulosis. So if it is pus within this breast abscess, when you push on it, you'll see the pus kind of swirling around. Whereas if that's a solid lesion, pushing on it's not going to squish it and not going to cause that pustulosis. So my top scanning tips for you are to hold the probe correctly and hold it quite low down so you've got maximum control over it. We also need to have something anchoring our hand to the patient. So pop your little finger out so that it's actually anchoring on the patient. If you do not like gel, you're going to have to wear gloves, because if you're not getting your hands dirty, you're not doing it properly. It's important to try to image the breast and make sure that our angle of incination is perpendicular to the breast tissue. So you can see here on the left side, the breast tissue is slightly on a lean, and on the right side, we've rocked our probe so that we're perpendicular to the breast tissue. And as with anything else on ultrasound, if we can hit it at 90 degrees, we get a better reflection from it. So we do need to just adjust our position so that we can get our angle of incination as close to 90 degrees as possible. Sometimes you may need to lower the frequency, particularly in very dense breasts. If you're struggling to penetrate through an area that has posterior shadowing, try lowering the frequency to make sure that it is it just dense breast tissue, or is it something we need to be worrying about? Take the time to optimize your B mode settings. It's very easy to kind of look at this and go, well, is that a lesion or is that a little bit of fat within some breast stroma? So make sure you adjust your settings so that you can visualize the breast tissue as best as you can. Color settings are also really important to optimize. If we're talking about a tiny little breast carcinoma, it will only have very small vessels, so we need to make sure our flow is optimized to show any color filling or blood flow within that area as best we can. When you're measuring a lesion, it's very important to make sure that you try to be as accurate as possible, because a lot of these ladies are coming for follow-up scans to see if there's growth and to monitor the lesion rather than just whipping it out straight away. They'll have serial scans at 3 months, 6 months, 12 months over a 2-year period to see if they're getting, if it's growing or if it's just staying stable. So it's really important to be careful with your caliper placement and make sure your measurements are as accurate as they can be. Now, the other thing when you're scanning the breast is reduce your speed. You don't want to be whipping over the tissue and miss a lesion. So you need to have a slow and steady and consistent sweep speed so that you enhance the visibility. The things that are different will stand out at you. So if you go too fast, you just whip through, you'll miss things. And if you go too slow, you can also miss things because you can't see the change as you're moving. So it can be challenging, I know, particularly in some settings where, you know, I know in some places I've been given 15 minutes to image 2 breasts and they're the size of basketballs and they're fibrocystic disease, and you're just battling right from the beginning. So it's very important, though, to make sure that we very carefully examine the breast, not going too fast, not going too slow. Large breasts or breasts that have lots of pathology can be quite overwhelming. So potentially you can survey scan, do 1 quarter at a time, do the upper outer quarter, survey scan that bit, go through and document your images. survey scan the next bit, and then document your images. Sometimes when they are very large breasts, or if they have lots and lots of disease, it's hard to figure out where you are and to remember where all the bits are. So if you take it 1/4 at a time, it's you can't eat an elephant all in one mouthful. You've got to just take it bite by bite. It's the sort of thing we're looking at. Now, these are radial and anti-radial images of a focal area, which is more subtle in comparison to the background echotexture. And so this was a real lesion, but could be easily missed. This is what scares me about breast ultrasound, to be honest. So it's really important that you're not going too fast. So hopefully there's been some tips there. We've looked at the anatomy, we've looked at scanning technique, some normal and abnormal appearances, and then some tips for scanning. And hopefully there's something there for each of you, or that you've learned or taken home some tips that will help you in your scanning practice. And now it's over to you guys. Does anyone have any questions?
I like pustulsis. Is that a real word?
Certainly in a point of care setting, we use pustulsis a lot.
I never know how to describe it. I don't know that I
heard it before then, to be honest.
No. The sort of medical officers asked me if they can have a go at breast abscesses, and I guess what would be your suggestion? Yes, have a go.
Well, you know what? There was a case, I remember this very clearly, someone who'd done a course with us, an emergency doc, and then went back and the patient presented, they'd been lactating, they had a hugely red and inflamed breast, and I had quite a strongly worded phone call from a sonographer saying, what are you teaching them? Now, we're not teaching them to drain breast abscess.
No.
We're not teaching, we are teaching them needle guidance techniques, but my thoughts here are, clinically, they're making a decision on what they're seeing. If you are strongly suspicious that that's an abscess and you see something that looks like an abscess on ultrasound and you're putting a needle in, surely it's better to guide it with the ultrasound into the right area. But there are pros and cons. It would have been done without ultrasound and blind anyway. So I don't know. It's tricky. You wouldn't want to mistakenly drain something that might be a bad lesion or something like that. But I think the clinical context here is super, super important. And at the end of the day, the doctors that are acting on the information they have at hand.
Yeah. Look, I thought it was great. I wish the trainees could have watched it when they started. So thanks.
Oh, well, it's on our back catalogue now, Chris.
Yeah, no worries. Thanks.
Does anyone else have any comments or suggestions? So Philippa was saying, I touched on ergonomics, resting a finger on the skin. She always puts a pillow on the patient's chest and tummy to lean her elbow on, is what I'm assuming you meant, Philippa. I agree. This can be really tricky. This can be really hard on your body. And I've done many days where it's breasts all day and you go home and your shoulders are really sore. It's really, really important. And I should have emphasized this more actually. It's really important to make sure your bed height is right. You get the patient as close to you as possible so that you're in neutral position as best as you can, and support your arm as best as possible so you're not kind of hanging it there, activating your muscles. I agree with you, Philippa. It can be a hard day when you're doing breasts all day. Henry, I haven't done much breast elastography. I think that was Henry. Has anyone else done breast elastography? Where did my chat go? Here we go. So what role can elastography play? I think I haven't done a whole lot of it. Philippa, have you done breast elastography? They gave up on it if there was a concern, it went for biopsy. I'd have to say I've not done like the high-end level breast for breast cancers and stuff for a long time. The theory, I think, is just to see how elastic it is, and the variability of how elastic that is tells you something about the lesion, but I couldn't comment. So sorry, I can't help out with that one. Pustulsis, it's getting a bit of a mention here. That's cool. Cool. All right. Well, thank you all so much for joining me tonight. As I said at the beginning, please feel free to check out the back catalogue of our previous episodes. If any of you have a suggestion for a topic next month, go to my email and at suean@ultrasoundtraining.com.au, and you can send through your suggestions for a topic. Check out our Train the Ultrasound Trainer course, and for those of you who are teaching or POCUS educators or sonographer educators in the ED, feel free to join us on Facebook in our Facebook group. So thank you so much for your time. We appreciate that, and hopefully we see you all next month. Ciao.